Hello, my name is Claire Boothroyd and I'm the president of Aspire. Today I have the great privilege of speaking with Dr. Rupin Shah, who is an eminent urologist from Mumbai. And we're going to talk about varicoceles today. So, Rupin, thank you and welcome.
Pleasure being here.
Now, I'm hearing, and I gather there's some data, that we're tending to miss varicoceles in our assessment of the male patient who may be in an infertile relationship. So how should we, as obstetricians and gynecologists who treat couples with infertility, deal with this issue of the varicocele?
I think it starts by realizing that the sperm is important and a healthy sperm is important. And there are many causes that could make the sperm not so healthy. And one of the commonest correctable causes is a varicocele, which is basically a dilated bunch of veins around the testes, which thereby changes the temperature and the chemical milieu and can harm the testes and the sperm quality.
Right. Now, of course, gynecologists are not particularly comfortable necessarily in examining males. So is it okay to just do an ultrasound to sort this matter out?
I'm so glad you asked me that question because it's the problem. OBGYs are using ultrasound as a substitute for a physical examination, and that is not right. It's the physical examination which is the basis of further testing. If you directly send a patient for the ultrasound, and a lot of my colleagues unfortunately do that, the sonologist will find some grade of varicocele, but which is not significant clinically, because if the ultrasound says there's a varicocele, but when I examine the patient, I don't feel anything, that would be called a subclinical varicocele. And the vast amount of data available tells us that treating a subclinical varicocele is not right. So you're putting the cart before the horse if you do the ultrasound first, and you create confusion because now the patient has a report, varicocele. He goes to Google, reads about varicocele, and says, I need surgery, when really he doesn't. So the first step is either the OBGY should start examining, or make sure you have a good, sensible urologist, andrologist on your team, examining hopefully all the men, or certainly at least those who have low sperm counts.
Okay, so when we examine a man for a varicocele, let's assume that he might have some adverse seminal parameters. We're going to examine him standing up to look to see if there's varicose veins around the testis. Is it important to do a Valsalva maneuver, or is that not really needed?
So you grade a varicocele. Sometimes you will feel it only when he's doing a Valsalva. And sometimes it's a bunch which is felt even if he's just standing. And sometimes it's such a big bunch that anyone would diagnose it. So you would use the Valsalva to diagnose an early varicocele. And also when doing an ultrasound, the Valsalva is used to accentuate the reversal of blood flow, which is what happens during the varicocele.
Mm. So really, we need to do an examination first, and then if we are suspicious of a clinical varicocele, you might use an ultrasound to confirm it.
Yes,
but really, the role of ultrasound is probably not that important. Is that right?
Yeah, it's more confirmatory because if you're thinking of surgery, you want some documented proof, but it's not the first step.
So if a man has an abnormal semen analysis and a clinical varicocele, is there evidence of benefit for surgery?
So this has been a major controversy. The earlier Cochrane database reviews actually said varicocele repair does not help, but now that's changed. Now I think there's uniform consensus that correcting a varicocele will improve semen parameters, will improve the pregnancy rate, limited data that it probably improve the live birth rate.
Right. So there's really good evidence that if a man has a semen analysis, we should definitely look for a varicocele and be sure that he doesn't have one. What about the setting of recurrent pregnancy loss or recurrent miscarriage, repeated miscarriage?
So that again brings us to a very interesting area where in the presence of recurrent miscarriages, the focus is on the woman, and we forget that the sperm could be equally responsible. And one of the important causes of the sperm leading to RPL is poor DNA or high DNA fragmentation. And a varicocele is one of the correctable causes of high DNA fragmentation. So it's quite possible to have a scenario with recurrent pregnancy loss. The semen test shows elevated sperm DNA fragmentation. Patient has a large varicocele. The varicocele is corrected, the SDF drops, and there's no miscarriage, and pregnancy happens and continues full term.
And is there good evidence from clinical studies that
Sure.
varicocele repair improves the
Yes, there are
ongoing
studies that have shown higher pregnancy rates and lower miscarriage rates after the varicocele is corrected. And obviously, that's not for all varicoceles, but a varicocele with the presence of elevated sperm DNA fragmentation would certainly be an indication for surgery.
And is it difficult surgery to do, Rupen?
So the current gold standard is a microsurgical subinguinal varicocelectomy, which does require specialized training and a certain learning curve to get to that point. But there are many other approaches, and what we tell people is if you're not trained in microsurgery, do whatever it is that you're doing well, and that'll probably do equally well too. But ideally, yes, you want it microsurgical because that would have the least complications and the highest success rate.
Great. So I'm just going to recap here. So examination of the male is really important if the semen analysis is abnormal, and also if there's recurrent pregnancy loss. And if there's a clinical varicocele present, there seems to be evidence of benefit from at least considering surgery for the varicocele. Perhaps a more controversial area, I think, is if the man has azoospermia and has a clinical varicocele. What's the evidence there, Rupen?
As you said, that's really controversial. So that's why the AUA guidelines kind of tell you to ignore the varicocele in the context of azoospermia, while the European guidelines are in favor of the varicocele being corrected. What all the studies put together suggest is that in about 40% of men with azoospermia, and remember the first reported case of varicocele in literature was an azoospermic man who was operated for a varicocele. So the study suggests that maybe 40% of men will have return of some sperm in the ejaculate after correcting a varicocele. However, in the majority, this will reach relatively low counts, 1 to 3 million. So they will still need IVF fixing, but that will be possible with the ejaculated sperm. In some cases, this sperm is transitory. They may become azoospermic again. So we need to freeze the sperm when they come. And finally, and this is interesting, the evidence suggests that even if no sperm appear in the ejaculate, the chances of testicular sperm retrieval are improved by correcting the varicocele.
That's very interesting. So in the setting of azoospermia, where there is a clinical varicocele present, there may in fact be benefit of operating on the varicocele and then doing repeated semen analyses, because that azoospermic man may become either severely oligospermic or cryptospermic, but at least have sperm in the ejaculate that can be frozen and potentially used for ART. This has been a most wonderful conversation, very stimulating, and I do hope that you have learnt something today, and I would like to thank Rupen for giving up his time and being such a clear speaker. Thank you very much.
It's a pleasure, and it's always nice to remind the OBGY that there is a man behind the sperm and there's something we can do for him. Thank you, Claire.
Thank you.